Thanks for joining us. Today, I'm going to be talking about understanding psychosis. And so for us at the UC Davis Early Psychosis programs, we really see this training as foundational to much of the work that we do. We use this sort of information and we present it to families, we share it with each other, with other colleagues. So we really see this as a foundational course. As I'm going through today, please hold your questions until we get to the breaks. So again, my name is Dr. Tara Needham. I'm a clinical psychologist and I'm the executive director of our early psychosis programs. I've been working in this field for about 20 years now. So I'm very excited to be here today to talk to you about this important topic and to answer your questions. So today in this presentation, I'm going to cover a number of different topics. I'm going to talk about what psychosis is. We're going to dive into symptoms and clinical features. We're going to talk about DSM criteria, differential diagnosis, the mental status exam, and epidemiology. We're going to talk about how psychosis develops, the course of illness, the high risk period, and prognosis for outcomes. We're going to talk about what causes psychosis, at least what we know so far, and we don't have exact answers. We're going to talk about treatment options, and then we're going to talk about how to screen and refer to our clinic. So I know when I go out into the community, ride an airplane, go to a party, and I talk to people about what I do and the folks that I serve, I hear a lot of very common misconceptions. And so I always take those opportunities to make sure that I help to clarify things to reduce stigma for those in our community who may be experiencing psychosis. So maybe you've heard some of these too. It's the mom's fault. Oftentimes in mental health conditions, we look to the family and we look to the social environment for potential causes. But for schizophrenia in particular, there was a causal hypothesis about the schizophrenogenic mother and the concept of double bind communication. So this difficulty in communicating is what created psychotic symptoms. I want to say this is an old hypothesis. This is not what we believe today. And so it's really important. And this is something families struggle with. Parents will struggle with and say, was this my fault? Did I do something wrong? And it will come up in the social and familial context, as well as in the genetics context, as we think about this disorder. Okay. Split personality. This is the other one that I hear a lot. And when we think of the original German of schizophrenia, it does mean split mind or split brain. But that's not what we're talking about. Multiple personality disorder, dissociative identity disorder is what we think of when we think of split personality. And that is not one of the topics we'll be discussing today. It only happens in males. This isn't true. It tends to occur a little bit more frequently in men than women, but really that's shifting as we learn more about the illness and its presentation. We're seeing that oftentimes women have better outcomes, and so they haven't been counted in many of the studies. So it's important to know that this happens in both men and women. That individuals can't function in society. And this is this sort of, I hear people talk about psychosis is like going off a cliff. Well, that's a horrible thing to say. You wouldn't fare well at the bottom of that cliff. We really want to present a very hopeful idea for folks and their outcomes. People don't want to have a psychosis diagnosis because of what they believe it means for outcomes. And those things are really shifting with better treatments. And so we want to make sure that people understand that as their treatment providers, our goal is to get them back on the same trajectory they were on before their diagnosis. And so they can go accomplish all of the things they want to accomplish with their psychosis as they could before it started. that individuals are violent and dangerous. This is something I hear a lot. And, you know, individuals with psychosis are no more violent and no more dangerous than individuals with other psychiatric conditions. It's really the same percentage-wise, but it's been amplified to be this disorder with a high risk of dangerousness. Actually, individuals with psychosis are more at risk of being a victim of violence. And so that's something we want to be very careful in working with individuals to make sure they have good safety skills and are able to take care of themselves so that they aren't a victim of violence. Homelessness. Folks often think that the individuals that they see who are homeless always have psychosis, and that's not the case. Homelessness is a challenge for our society as a public health crisis, and many individuals who are unhoused are struggling with a variety of different difficulties, some of which may be psychosis, but that's not always what will happen for an individual who has psychosis. So here are some individuals that really represent the reality of living with psychosis symptoms. So all of these individuals have been upfront about experiencing psychotic symptoms as part of the constellation of mental health symptoms that they experience in their lives. So you may recognize some of these folks. Some of them are with us still and some of them are not. And but they are all very successful people. And, you know, actors, singers, actresses. We have John Nash, who's a mathematician, and Ellen Sachs, who is a law professor at USC. So you can see here that living a full and exciting life is possible if you have psychotic symptoms. I do want to note on this slide that if we were talking about depression, or we were talking about substance use issues, there would be so many faces on this slide that we wouldn't be able to tell them apart. So I want to highlight here for a moment that these are the folks who've been brave enough to talk about their psychotic symptoms as part of their mental health challenges. And that really speaks to the stigma that many people hold related to their own symptoms, as well as the pervasive stigma that still exists in society. So one of our challenges as mental health providers is to help talk honestly and factually about psychosis, and help our clients achieve the things they want to achieve, so we can really shift these views for individuals and for our communities about what psychosis means. Okay, so let's shift into talking about the constellation of experiences that make up psychosis, or that are experienced for individuals with psychosis. And one thing that I want to point out is that not all individuals experience all of these symptoms. Psychosis is a very complex disorder, and you know, individuals can look quite varied and diverse. So it's really important to know that these symptoms that we're going to talk about don't happen the same way for everybody. It's not as homogeneous a population as you might see perhaps in depression. So to just really keep that heterogeneity in mind. So when we think about psychosis, we talk about clinical symptoms, and these are categorized into 3 different groups. Positive symptoms, I'm going to go into these in detail. So positive symptoms, negative symptoms, and disorganized symptoms. Of course, when we think about making a diagnosis of a disorder, we're going to talk about symptoms, and then we're going to talk about functional impairments. And especially, we're going to look at functional impairments in the social and role domains. Additionally, psychosis is also characterized by cognitive impairments, both in what we call general cognition as well as social cognition. So we're going to think about those a little bit today. So let's talk about each of these symptoms. Positive symptoms are not called positive because they're good. They're called positive because they're exaggerations of normal human experience that aren't tied to reality, are held with conviction, even in the face of contradictory evidence, and they negatively impact everyday functioning. So I want to pause for a second and go back to the first part of that definition. Exaggerations, amplifications of normal human experience. This is not how most of us were trained to think about psychosis. We were trained to think about it as something unusual and aberrant and different. And that's not the case. It is on a continuum with normal human experience. And so as we go through and we talk about these experiences over the course of this presentation, I want you to just really keep that in mind. There have been times when all of us have had our minds play tricks on us. Maybe we thought our cell phone was going off when it wasn't, or we see something out of the corner of our eye and we turn and nothing's there. That is part of the normal continuum of psychosis. Okay, so let's say we're now talking about the end of this continuum in which someone needs treatment, and they need treatment because these experiences are impacting their everyday functioning. So what makes up positive symptoms? So the first group is delusions or unusual thoughts. So again, these are thoughts that are held tenaciously with conviction. You can't convince me otherwise. They impact my behavior. I act because of these thoughts, and they impair my functioning. The most common of which is paranoia or suspiciousness, thinking that people are out to get you or trying to harm you. You can also have thoughts that people are putting thoughts in your head, taking thoughts away from you, or thinking you have special powers or gifts, thinking that you are able to see symbols or signs in what's happening around you. Those are called delusions of reference. There's a variety of different types of delusional thinking. Next, we have hallucinations. So these are distortions in any of our 5 senses that we think are real. So the most common is auditory. So hearing things that aren't there, can be as subtle as mumbles or whispers or footsteps or knocks, all the way up to hearing voices shouting, screaming at each other or at you. You can also have visual hallucinations, so seeing things with your eyes, again, which can be as subtle as seeing a vague shadow to being able to make out a fully formed person or figure or an object even that isn't there. You can also have somatic, so feeling things in your body, feeling bugs crawling around in your brain, feeling something touching your internal organs or someone touching you when no one's there. Olfactory, smelling things that aren't there, and not listed here, but additionally gustatory, so tasting things that are not there. So these are hallucinations. And then there's what we call thought disorder, which is also disorganized communication or thought blocking. So these are the things that, when you say in a mental status exam that someone is, their thoughts, their speech is linear and goal-directed, meaning you can follow one thought to the next, and they follow each other, and you're able to kind of track what the person is saying, and they get to the goal that they were intended to get to. So linear, goal-directed. When an individual has thought disorder, they're having difficulty organizing their thoughts in this way. And so things can seem sort of jumbled. You can get circumstantiality, which is way more details than you need. You can have derailment, where somebody slowly slips off track. You can have tangentiality, where you ask someone a question and they answer you over here. And you're like, wait, that wasn't what I was asking. It's very confusing. You can have a logicality, where things don't link together in a logical way. So there's lots of different ways in which individuals' thoughts can sort of not be organized. And what I find as a clinician when I'm working with folks who have thought disorder or disorganized communication is that I end up getting very confused. I have a hard time sort of keeping things in order, or I have to work really hard to keep things in order. And at the end of what tends to be a much longer period of time, interview session than I had anticipated, I am very tired. And it's because I have been trying to do the organization for the person. So those are some clinical clues when you might be dealing with thought disorder. All right, so that's positive symptoms and disorganized symptoms. Negative symptoms. Negative symptoms are a loss or a withdrawal of qualities that make us emotionally connected and motivated human beings. So that's why they're called negative symptoms, this loss or this withdrawal of these qualities, okay? So the first of those is anhedonia. This is a loss of interest in pleasurable activities where fun aren't fun anymore. Could be social interactions or hobbies, video games, movies, family connections. The things that brought the person pleasure before are kind of blah and disinteresting now. You can see how this crops up in depression as well, but it's also a feature of psychosis. And when you have things not be as fun as they used to be, you tend to not be motivated to do them anymore. And so as a result, folks can end up pretty isolated. Avolition is another negative symptom. It is a lack of motivation for goal-directed behavior. So we like to call it the get up and go to get things done. Work, school, chores, self-care and hygiene, the things that all of us do. You have to have motivation and energy to get them done. And so when you're experiencing avolition, there isn't that energy. I remember a mom of a client describing her son as a lump on a log. He just had no get up and go to do even the most basic activities. Then there's flat affect. So when we communicate, we don't just use words. We use the tone of our voice. We use our hands. We use our face. We use our bodies. And some of us, like myself, are more animated than other people, but we all tend to use these things to communicate what we want to say. So when an individual has flat affect, you will tend to see a reduction in these qualities. So they may not gesticulate as much, use their hands or their bodies to communicate as much. They may not use their face. You might not see the smiles or the sadness or the angriness that you would expect. You might see a dulling of the facial affect. And then voice, you may begin to hear it become much more monotone, and you don't really get the inflections that you would expect for someone who was telling a very important story. And as a result, it can be very hard to maintain your interest in what they are saying. It can sound almost robotic at its most extreme. So, these symptoms, flat affect, when they come on, the person can seem very withdrawn, maybe not even make eye contact, and be minimally communicative in their face and their body in terms of emotional expression. And then with that can go poverty of speech. So this can be reduced verbal output just in terms of quantity, or it can be in terms of quality. So, you could ask somebody, so what did you do this weekend? Nothing. Then you might follow up and say, did you do anything fun or interesting? No. You get these very short sort of answers. And I want to separate this from somebody who is not communicating in an oppositional way. They don't want to tell you. That's different. There's really just not much happening to give much verbal output. Alternatively, you can get a lot of words that don't really tell you much of anything. So, what did you do this weekend? I don't know, I don't know. I went out, I don't know. Whole lot of words there. And all you got out of that was they went out, right? So then you have to ask another question. Well, where'd you go out to? I don't know, I went out. I went around, I don't know, some places, Still, you have no idea where they went or what they did. Got a lot of words, not a lot of content. So these are different negative symptoms. And they again, individuals may have a constellation of these symptoms. They may have one, they may have none. Similarly to the positive symptoms, you could have someone who has just one. They have voices. They don't have delusional thoughts. They don't have disorganized communication. They don't have negative symptoms. This can be And this is what can make it tricky to sometimes understand that psychosis is what's going on. When I get to DSM diagnosis, I'll sort of talk about the requirements for a particular diagnosis, but then you'll see how these individual symptoms fit together into clusters that we call diagnoses. So really these symptoms I'm talking about are the building blocks. I think it's also important to touch here in negative symptoms, when we think about what this may look like. So I mentioned that anhedonia and avolition can also look like depression. There are other disorders that can look like negative symptoms. So, you may have an individual with a neurodevelopmental disorder like autism who may not be particularly interested in social interactions and have difficulty in social interactions. But one of the important pieces that you want to use in terms of your differential is that an individual with autism will have long-standing difficulties in social interaction and social motivation. Whereas somebody with psychosis who's experiencing negative symptoms, that's going to be a new thing or a different thing for them. It'll be a symptom that comes on as part of the illness. Now, where this can get very, very tricky in terms of differentials is when individuals have struggled for a long time before they develop psychosis. And then it can be hard to kind of say, well, wait, how long has this social difficulty been going on? And that's where it's really important to gather as much data as you can, because it could be two disorders. You can have someone with autism and psychosis. And so you want to make sure you're collecting enough symptoms and not double dipping to give those two different diagnoses. Okay, disorganization. So I talked about some of these a little bit under the positive symptoms, but we also, here's a good listing of disorganized symptoms. So we have disorganized communication there at the top, and we also have disorganized behavior. So these are unpredictable or strange behaviors or reactions that don't fit the situation. So some of these, you may see individuals dressing inappropriately for the weather. So they have 3 coats on and it's 95 degrees outside. One of the things I tend to learn is that oftentimes individuals are doing that because of a reason, because of one of their other symptoms. So to just keep in mind that oftentimes these unusual behaviors are being driven by psychotic symptoms. So they're a response to the psychotic symptoms. So shouting, laughing, crying for unclear reasons. And so again, asking, when you see these unusual behaviors, asking why. I'm wondering why you're wearing 3 coats. I'm wondering why you're laughing right now while, I'm talking to your mother. Trying to understand what's happening for that individual internally. Catatonia is a diminished responsiveness to the environment. So for those of you who took abnormal psychology, you might have seen pictures of catatonia in your textbook. Oftentimes it's an elderly person who's posed in some strange shape, and that's called waxy flexibility. So at its most extreme, catatonia, folks are unresponsive and they're sort of rigid in their posture and can be posable. This is very, very rare and uncommon. What we tend to see more is individuals just sort of unresponsive. I had one young woman who laid on her bed unresponsive for about 18 hours until her mom found her. Her mom rolled her over and she was clearly awake and breathing and all of those things, but she wasn't responding to her mom. And so the ambulance came and took her, and she was diagnosed with catatonia. So these are the times where, someone will come up to your client and try to touch them or call their name or whatever, and the person doesn't respond. It's often seen when people don't get appropriate treatment and can be seen as a negative symptom as well. So this loss or withdrawal of engagement with what's happening around you. So really, one of the things we've learned over time with disorganization is that this is an impairment in goal-directed behavior. So the brain's ability to organize what is happening and the response that it wants to produce and then produce that response. And this is highly correlated to prefrontal brain functioning. So this is your frontal cortex, this big front part of your brain. Some folks call it the executive control center. It controls a lot of different things related to the brain. But one of the things it does is it helps us to sort of organize our behaviors towards whatever goal we may have. And so that can even be in production of speech or behavior. So we see that folks who have a lot of these disorganized symptoms, they have a difficult time coordinating the PFC, the prefrontal cortex, with whatever other part of the brain is responsible, be it the motor region or visual attention regions in the back or memory systems in the temporal lobe. You see this lack of integration between those brain regions when they're trying to complete an associated task. So again, this is a brain-based difficulty that we're seeing associated with psychosis. All right, and so this comes to cognitive impairments. Good transition. Psychosis is a brain-based neurodevelopmental disorder. Now, for some of you, that could be really surprising information. I think it's really important for us to keep in mind that the majority of mental disorders are brain-based abnormalities. And for psychosis in particular, it is a neurodevelopmental disorder. So we see it emerge over the course of early adolescence into young adulthood. So this again is why some of the symptoms can be difficult to differentiate from other neurodevelopmental disorders. So it's important to keep those things in mind. So when we see on average in individuals with psychosis, we see difficulties in a variety of cognitive areas. So attention, working memory, problem solving, and cognitive control. So here is an image. This is imaging work that comes out of our lab at UC Davis. And you can see here's the prefrontal cortex. This is the dorsolateral prefrontal cortex. And this is the parietal lobe. This is a visual attention network. The connectivity between these two regions really helps an individual be able to pay attention and guide that attention to the appropriate information in the environment to be able to make a response. And as I just mentioned, what we see is a lack of coordinated activation between the prefrontal cortex and these other regions, and that's what contributes to some of the cognitive difficulties. So difficulty focusing, maintaining attention, working memory, difficulty taking little bits of information, holding them in mind, and being able to follow up. So for example, I'll tell my 5-year-old son, take your socks, put them in the laundry, go brush your teeth, and put on your pajamas. Well, that's multiple pieces of information, tasks he has to remember, as well as objects he has to remember. And there was kind of an order there too. And so for an individual who has difficulty in working memory, they only might remember a few of those or not get them done in the right order. And so that's a working memory problem. Problem solving, being able to think through complex issues. Maybe it's a homework task. Maybe it's a project at home, but being able to think through things and come up with an appropriate solution. And then cognitive control. This is this ability to focus on the information that is necessary to execute a particular task. So knowing that in a particular situation, this behavior is required and not this behavior, so that I can make the appropriate response and get the outcome I want. So an example there is knowing which way to look when crossing the street in London versus Los Angeles. Got to look 2 different ways so you don't get hit by a car. So that's sort of this rule or goal-directed behavior. So these are areas in which individuals with psychosis can struggle. And you can see how these could affect school, at home, being able to follow, directions from family members. It can be very challenging and frustrating. And so many individuals need extra supports in school to be able to complete the tasks that they need to complete. Additionally, social cognition can be an important part of psychosis. So this is difficulty processing social and emotional information. So emotion perception, there's a large research literature that shows on average, individuals with psychosis have difficulty perceiving facial affect. They are more likely to perceive neutral facial expressions as threatening compared to typically developing individuals. So one of the things I think is interesting about that is that as a clinician, we may be sitting there quietly with a blank expression listening to our client, but they may misperceive our facial expression. So it can be important for us to, use our face to communicate our feelings and then make sure we're verbalizing how we're feeling so that individuals don't misinterpret our facial expression. But this comes up a lot in social interactions, this idea that, people are looking at them or have malintent. This could be part of the illness and a tendency to misperceive what's happening in their environment as opposed to what's actually happening. Regulation, emotion regulation, being able to identify one's feelings and manage them appropriately is something that is also can be challenged in individuals with psychosis. So key emotion regulation areas are up here in this very frontal part of the brain called the orbital frontal cortex. And it helps to regulate a variety of emotional responses that come from midbrain structures like the amygdala. And so when these areas are not working as efficiently as they could, you're going to get all sorts of misfiring and inappropriately regulated emotional behaviors. Finally, theory of mind. And this is something that really does come from the autism literature, but this idea of being able to understand what other people are thinking and intending can also be impaired in individuals with psychosis. So one of the important pieces to keep in mind is that oftentimes these impairments are present prior to the onset of positive symptoms or even negative symptoms. So individuals may be struggling in school, may be struggling to make friends. That could be in their history before these other symptoms crop up. But these symptoms are very predictive of everyday functioning. So if they have difficulty with social cognition, that's something that will really be predictive of their social functioning and can be particularly challenging to treat. Okay, functional impairments. So important here is that everyone wants meaningful roles, goals, and relationships in their life. All of us want friends. All of us want to have meaningful activities such as work or school. This is important as humans. And so the different symptoms, the cognitive symptoms, the positive and negative symptoms, when these things are happening, they can really frustrate individuals' ability to achieve these goals in their life. So some of the areas we want to keep in mind are role functioning. This is responsibility and involvement in job, school, home, and community. Is someone able to work? Are they able to attend school? Are they able to do it part-time, full-time? How much support do they need to be successful? Are they able to contribute in their home environment, do chores, take care of other things? Are they able to participate in their community meaningfully? These are really important areas that we want to support our clients in achieving. Then there's social functioning. It's not just about the number of friends, it's about the quality of that relationship. Are individuals able to make friends and keep friends, trust people, share things, and get what they need from those relationships? That's also particularly important. These functional impairments are most strongly related to the severity of negative and cognitive symptoms. It's very impressive how many individuals can hear voices and still hold down a job and still have friends. So really the positive symptoms for some individuals can be very debilitating, but for other individuals, that's not the most debilitating aspect of the illness. It's often the cognitive and negative symptoms, but often the treatment focuses on positive symptoms. So I say this all to make sure we're paying attention to that full picture of symptoms that can be related to psychosis, so that we're making sure we're providing support and treatment to help people get back to everyday life. Another important note that I've sort of alluded to but haven't made specific yet is functioning prior to illness onset tends to predict outcome and should really be considered in developing treatment goals. So where someone was prior to the development of their positive, negative symptoms is where we should be trying to get someone back to after treatment. So if someone was in high school, general education setting classes, participating in the swim team, and had a small but close set of friends, that's our goal for treatment. Our goal is not, you know, some sort of special residential placement or something. No, our goal is to get them back to independent functioning in a high school setting with friends. So really using prior functioning to predict your treatment goals. So let's take another example. Someone was in special education, had very few friends, and always has had difficulty with self-care. So really be mindful of that after psychosis has set in. So you're looking, you know, maybe they won't be in an independent educational setting. Maybe they'll still be in a supported educational setting. You know, you'll still want to support them in social functioning goals, but maybe having one or two friends would be a huge improvement for this individual. And then hygiene and self-care may be an ongoing struggle, and so you'll work to manage that as well. But this can be important in terms of thinking about what your expectations are and setting appropriate goals, but also family members setting appropriate goals for them too. Okay, so now let's start to talk about some of the complexity of psychotic symptoms. These occur in a variety of diagnoses. So I mentioned, you know, these symptoms fit together in clusters in different ways to meet criteria for a particular DSM diagnosis, okay? So we have what we call non-affective psychosis, which means that the primary illness is psychosis symptoms, usually meaning positive symptoms, but also negative symptoms. So positive symptoms are primary, even if there are affective symptoms. So like schizoaffective disorder, positive symptoms are primary, they are around even when affective symptoms are not. So primary psychosis, affective is secondary. Then you have affective psychosis. So in these disorders like bipolar disorder, depression, and PTSD, your affective symptoms, depression, mania, anxiety, those are primary. And then you'll see psychotic symptoms and they pop up, but they also go away. So affective psychosis, affective symptoms are primary, psychosis is secondary. And then you can also see psychotic symptoms in other disorders. So for those of us who have experienced, you know, loved ones who have neurodegenerative disorders like dementia, Alzheimer's, Parkinson's, you'll see psychotic symptoms crop up as the individual experiences changes in neurotransmitter systems or brain structure. So it's common in aging. We also see it in borderline personality disorder. You can see what seems like delusional thoughts, paranoid thoughts, or even hallucinatory experiences. But in borderline personality disorder, it usually occurs during a period of intense interpersonal distress, and then it goes away. So it doesn't really persist for a prolonged period of time. You can also have it substance induced. So you can have the symptoms come on in a period of intense use of a substance or as part of a withdrawal syndrome. And then you can have it from injury to the brain, from a head injury, from seizures, from a tumor. So these are all other ways in which impact to the brain from substances, aging, or trauma can also cause psychotic symptoms. So let's focus on the kind of penultimate psychotic disorder, which is schizophrenia. And think about how the symptoms we've just discussed fit into DSM criteria. So here's the DSM-5 criteria for schizophrenia. Criterion: 2 or more of the following for at least 1 month or longer, and at least one of them has to be 1, 2, or 3. So I think this is a big change from DSM-4, where you could have a constellation of any of these 5, but now you have to have at least delusions, hallucinations, or disorganized speech, which are really considered to be more characteristic of psychotic illness. Disorganized and catatonic behavior and negative symptoms can be part of the 2, but they can't be, you can't have those 2 alone. So it has to be some combination of these. So you could have delusions and hallucinations, or delusions and disorganized speech, or hallucinations and disorganized behavior, or hallucinations and negative symptoms. You can see how you can have a huge variety of combinations of these symptoms and receive a diagnosis. Then you have to meet criterion B, which is impairment in one of the major areas of functioning for a significant period of time since the onset of the disturbance. So that can be work, social functioning, or self-care. And then the symptoms have to be present for at least 6 months with at least 1 month of active phase symptoms. You could have periods of residual symptoms where only negative symptoms are present. So an individual has maybe delusions, hallucinations, and negative symptoms. And over that 6-month period with treatment, the delusions and hallucinations get better, but the negative symptoms persist, and that you can still have those residual symptoms. Criterion D, and this is what separates schizophrenia from an affective psychosis. So here, this is what is your sort of differential question. No major depression or manic episodes occur concurrently with active phase symptoms. So that's trying to say, like, do you have mood and psychosis together, or are they separate? If mood symptoms have occurred during those active phase symptoms, during the delusions or hallucinations, they have to be present for a minority of the total duration of active and residual phases. So what this is really trying to get at is when you have a whole lot of psychosis and you have blips of mood, you're looking at something like schizoaffective disorder, potentially. You can have a mood disorder superimposed on schizophrenia. But really, if you have a lot of mood with psychosis in there, you should be looking at an affective disorder. The disturbance is not caused by the effects of a substance or other medical condition. This can be very difficult to figure out, especially for substance use, because we are seeing more and more that individuals use substances and it triggers the onset of their illness, and those symptoms persist even when the substance use is stopped. And so that you would be looking not at a substance-induced disorder, but you would be looking at a primary psychotic disorder. So here is that, they've added this for DSM-5 to help with that autism differential. Because again, remember back in DSM-4, you could have disorganized behavior or disorganized speech and negative symptoms and be diagnosed with schizophrenia. And what we saw was that a lot of folks were misdiagnosed with schizophrenia when they actually had autism, or vice versa. So we want to make sure that we're considering these two things as separate. So if there's a history of autism or a communication disorder with a childhood onset, the diagnosis of schizophrenia is only made if prominent delusions or hallucinations, along with other symptoms, are present for at least 1 month. So it's really saying you need to have these classic positive symptoms to meet for schizophrenia in the context of a neurodevelopmental disorder like autism. So differential diagnosis is key. We're really looking between, trying to figure out, there's all of these diagnoses where symptoms can be shared. Anhedonia and avolition can look like depression. Disorganized communication can look like a developmental disorder. What do we do? These things can all look the same. So really trying to think about, as you're making your differential, what things do you need to know to be able to be thoughtful? You need to know the symptoms. You need to know what they are and really try to understand them. Be able to describe them in some detail. You want to know the factors that could be influencing those symptoms. Is there substance use that's part of the picture? Have there been general medical conditions that are part of the picture? And then are there any life events that could be contributing to this? So what I really like to do is to draw out a timeline of symptoms and life events. What's been happening and when did these symptoms go up and when did they go down, to get a sense of how all of these different factors may play a role in the presentation that I'm seeing today. You could have someone present to you who's very, very paranoid, and you start to talk to them and you realize, oh wait, they were involved in some sort of group of individuals who were dealing drugs and they lost the drugs and now someone's threatening them. Well, then their paranoia is grounded in reality. So we don't want to give them a diagnosis of a psychotic disorder when really there's a life event that's contributing to their presentation. So this is why it's so, so important to understand this full picture of an individual's life. You get this information from everyone. You look at every available source that you possibly can, any records you can get. If they'll allow you to talk to family, please do so. Make sure you understand the full picture. And then know that this is not a static process. Diagnoses change over time as you get information, as the illness evolves. This diagnoses may change. And so one of the things that is very important in talking to clients and families is for them to understand, this is the cluster of symptoms and impairments we're seeing right now. And right now that fits into this diagnosis. As we get to know you and your loved one over time and we gather more information, this diagnosis may change. They are not set in stone. They're just a way for clinicians to be able to communicate with each other in a very succinct fashion. So, and for you to know that you should also take information in and revise an individual's diagnosis as part of it. So, you might wonder, how far back should you go? That's really, it depends on you. One of my questions, I like to ask people how they were as a little kid. What were they like as a little kid? What were they like in kindergarten, first grade? And try to get a sense of how things were and where they were back then. And you could find out, okay, typically developing, no big things. Okay, things really started to change in high school. All right, well then move your timeline up to high school. And so that way you'll be able to kind of say, well, at least this individual was typically developing. And then we started to see this change. For some folks, that you'll start to see back as early as, childhood, they were experiencing repeated traumatic events that led to the onset of a mood disorder. And then when they hit middle school, there was substance use issues and more traumatic events. And then they began to develop hallucinations and delusions in late high school. But it's really important to know that there's this extended history of other factors, stressful factors, that may have contributed to the development of the symptom picture you're seeing now and also warrant treatment. So you're going to want to make sure okay, substance use, although not current, is something I want to keep an eye on. And then this individual also has a trauma history. So I want to make sure that we consider that as well in our conceptualization of, the symptoms we're seeing. If we're seeing paranoia, is that better explained by their trauma history than, what they're saying now? So to keep all of these complexities in mind. Okay, so affective versus non-affective psychosis. I've talked about this a little bit already. So just really trying to understand, is it a primary mood disorder with psychotic features as part of it, which means perhaps, the mood starts to ramp up into mania, and then you begin to see these sort of grandiose delusions. And as the mood starts to come down, the psychotic symptoms start to come down. Or no matter what the mood's doing, you see these periods of psychotic symptoms that persist beyond the resolution of that mood episode. And this is why knowing that timeline of symptoms is so important. Does the psychosis remit when the mood remits? Does the psychosis happen at times when criteria for a mood episode are not met? So they are having psychotic-like symptoms at a time when there's no depression or mania. Okay. So when we start to think about how these symptoms come together into our differential diagnosis, we're going to really need to think about the duration of these experiences and the clusters of symptoms that come together. So if we have symptoms for at least a day, but less than 1 month, and you only have one symptom, so they're only having hallucinations, they happen for a week, then they stop. So there's this return to baseline functioning. So we have more than a day, less than a month, you'll be looking at a brief psychotic disorder. If you have 2 or more symptoms, so you're looking at that cluster A. So let's say someone has delusions and hallucinations. They have it more than a month, but less than 6 months. So that 6-month duration criteria for schizophrenia has not been met. That's schizophreniform disorder. Now remember, if someone remits, fully remits and goes back to baseline functioning before the end of that 6 months, you can have schizophreniform disorder as your final diagnosis. It doesn't automatically convert to schizophrenia. So that's a really important timeline to keep in mind. So here's schizophrenia as well as schizoaffective disorder. So you have 2 of those criterion A symptoms. You have 1 month of active symptoms, 6 months total duration. Okay, so this is sort of a classic set of psychotic, non-affective psychotic disorder diagnoses. Now, what do you do if somebody has voices for less than a day, but more than a minute, and they're acting on them? They're really scared. Well, for those of us who do work in clinical high risk, we would be looking at this person as having brief limited psychotic symptoms, but that doesn't fit in brief psychotic disorder. So where do we put them? They would go in the other specified schizophrenia spectrum and other psychotic disorder group. So brief hallucinations is one of the examples that they give in the DSM for this diagnosis. We also use this diagnosis for attenuated or sub-threshold psychotic symptoms that meet CHR clinical high-risk criteria. Then, what about delusional disorder? So these are folks who have a delusion, a significant delusion, but they're functioning pretty well. It's been more than a month in duration. So the most common examples I've seen of this are individuals who are very paranoid at work, think something has happened to them at work, get angry, stuff happens, they lose their job, and they continue to sort of fixate on what has happened at that job. So they've lost their job, but otherwise they're functioning okay, and they don't have any of the other symptoms that we tend to see. Again, those 2 or more symptoms that are required for a schizophrenia or schizophreniform diagnosis. So that would fall into delusional disorder. Okay, so let's think about some examples here. So here on our line, we have normal mood or euthymic mood in the middle. We have super awesome, really good mood mania at the top. And then we have super sad, not so great mood, major depression at the bottom. So if somebody hits this top line, it's a manic episode. If somebody hits this bottom line, we're looking at a major depressive episode. Okay, so here we're going to try to combine mood and psychosis. All right, so if we were to look at this line, we see they're vacillating. They're going up and down between normal or euthymic mood and a major depressive episode. Back to euthymia, major depressive episode. Okay, so now let's say they experience psychosis as part of that major depressive episode. When the mood improves, the psychosis goes away. And then they have another episode of major depression, and then the psychosis appears again. So I want you to think for a minute, what diagnosis does this fit with? Are we seeing an affective psychosis or a non-affective psychosis? And within that category, which diagnosis should we be thinking about? If you've said to yourself, this looks like major depressive disorder with psychotic features, you were right. So here again, we have the psychotic features within the major depressive episode. Let's do another one. So here, again, we've got those major depressive episodes, return to euthymia, major depressive episode. What if the whole time there's psychosis in the background? So in euthymic periods, in depressive periods, we have psychosis. And right here at the top is normal or euthymic mood for more than 2 weeks. This would be schizoaffective disorder, depressed type. And so remembering here that you have to have this period of euthymic mood for at least 2 weeks to be able to give this diagnosis. So you're looking for those periods of psychosis in the absence of the serious mood impairment. That's what gets you to the non-affective psychotic disorder. Let's do another one. So here we have a manic episode, comes down, period of euthymia, and a major depressive episode. Sorry, I clicked. Let's go back. Manic episode, depressive episode. Now if we say there's psychosis this whole time, and we have these periods of normal mood for more than 2 weeks with these mood episodes superimposed on top of it, we're looking at schizoaffective disorder, bipolar type. because you have both manic and depressive episodes. You would consider schizoaffective disorder bipolar type even if all you had was manic episodes. Remember, for bipolar type, you don't have to have depression. All right, the next one. So here we have that same mania and depression, but we only see the psychosis in the manic episodes. So we should be able to say, oops, darn it, it disappeared. So this is bipolar disorder. Most recent episode, well, this would be depressed, but you would have mania with psychotic features. So that's what would be this diagnosis. So it's found in about 2% psychosis. I'm just talking about psychosis, right? Not schizophrenia, psychosis. 2% of the population worldwide. If we were to look in Sacramento County alone and look at incidents, so new cases of psychosis, there was this really great paper that came out last year by Radigan. This came out of the New York group looking in Medicaid data. It is much lower if you look at commercial insurance data. So if you look at Medicaid, the estimate, the low estimate was 272 per 100,000 new cases per year. So in Sacramento County, based on our 2018 census, that would be 4,191 people in our county. Again, that's the low estimate from that paper. If you look in, and so this is a really hot topic for us as we try to make sure we have enough service for folks. And what many of our programs are seeing is they're inundated. There's more people than there's staff to handle. And it's because we were underestimating the number of new cases that we should see each year. The old estimate was 80, around 80 per 100,000. So as going as low as 31 per 100,000. So, you know, really we've been underestimating. It's more common in men than women. We usually tend to see a 60-40, 65-35 split in our clinic. But there's questions about that there may be more women in the community, but as you see down here on one of the lower bullets, they tend to have a later onset. So the average age of onset for women is 22, and for men it's 17 to 18 years old. So here you have young men who are experiencing the onset of these very significant symptoms, like as they're graduating from high school, whereas women have a little bit more time, maybe to get to college, to get stable in a job, you know, to kind of get stable in the community before they become ill. And so there's a hypothesis that often that's this earlier age of onset that tends to create more men having more difficulty, which means they present more often for care. Whereas women may have, because they've had a later onset, some more time for brain development, again, establishing themselves in the community, they're able to manage a little bit better. So the mean age of onset is 20. We really talk about, if we want to talk about a normal distribution, right? So we have 20 here, right in the middle. And then 15 to 35 is kind of getting down to those tails. We go up to 30 in our insurance or our Medicaid clinic. We go up to 40 in our insurance clinic, and you will see women in that tail. You will have more women having onset later than men. We go down to 12 because we do see earlier onset as well, but very early onset before puberty. It's uncommon, but it does happen, and you guys will see it. Now that you know what psychosis looks like, you will see it in kiddos. And we get calls for 8, 9, 10, and 11-year-olds who are having psychotic symptoms. Psychotic-like symptoms are very common. If we were to go out into the community and survey folks, we will see that between 1 in 4 and 1 in 5 will endorse having a psychotic-like experience at some time in their life. And that is because, as I mentioned before, psychotic symptoms are on a spectrum from within normal human experience all the way up to fully psychotic, I need treatment. Just like depression, just like anxiety, just like substance use, psychosis is no different. So this sort of is a prototypical example of how we tend to see the onset of these symptoms. So here we've got positive symptoms in black, negative symptoms in blue. here's this at-risk phase. So I was sort of talking about this or alluding to this in response to one of my questions, one of the questions you all sent me before, is we see this ramping up of these symptoms, okay? And this shows us that the negative symptoms start before and get worse before the positive symptoms. So we've got folks who are blah, disinterested, unmotivated before they have odd thoughts or perceptual experiences, okay? We see this ramping up to what we would call acute psychosis, which may last a week to a month. And then hopefully someone gets some treatment. This is accurate diagnosis and treatment, not inaccurate diagnosis and treatment. And what we see here is a remission of positive symptoms. Most of our medications, which tend to be the first line, work okay for many people, not all people, in reducing the hallucinations and the delusions. But we see a persistence of negative symptoms. Medications don't work for negative symptoms. That's where psychosocial treatments are really important. So when we're talking about the early phase of psychosis, we're really looking at this early stage right here at the beginning, to get in as early as possible to put treatment in place to get folks back on track. So and that's because this period, the duration of untreated psychosis, is right now the best predictor we have of outcome. So the longer someone goes in the community without adequate treatment, the poorer is their outcome. So if we can get people into appropriate care sooner, we will get them back on track. So this is one thing that for our clinic and clinics like ours is a really important target for intervention. And that is because here in the United States, the average duration of untreated psychosis is 18.5 months. That's a year and a half. If this were cancer, people would be dying. So I want you to really think that people are out there in our community, hearing voices, having paranoid thoughts, not functioning well for a year and a half on average before they get treated. I have met individuals where it's been years. People haven't appropriately diagnosed or treated them for years. And this is common in the United States. It's worse when you go out into rural and remote regions. And again, I would point to stigma, as well as a lack of understanding of what psychosis looks like and how to do good differential diagnosis as reasons that are contributing to this. If we were to go to Australia or the United Kingdom, the average there is 3 months. The UK is trying to push it to 8 weeks. And in both of those countries, they have national early psychosis programs so that you can get access across the country. Everything here is state by state and county by county. So there's a very significant lack of access to appropriate care as well. So as I mentioned, this early psychosis phase, that first 5 years after the onset, is critical in terms of getting people into care. And that's because oftentimes in that stage, people still are functioning. They may be in school, they may have a job, they might not be functioning very well, but they have it, they have friends, they have family. And so what we're trying to do is help them maintain those things, bolster them within those settings so that they can continue to, improve and recover while maintaining these things, as opposed to waiting till they're gone. And now we're trying to recover them. So, the longer you let it go, the more those networks, those social networks, the job, the school, those things are going to fall away. And then you're trying to put those things back into place. And that's much, much harder to do. Here's some data that shows relapse, so a return of fully psychotic positive symptoms. So you can see here in blue, these are individuals where it was a year or more, so they had a long DUP, versus individuals who were identified within a year of onset. Here, shorter DUP, they're in orange. And you can see within 6 months of intake, both groups look about the same. 1 in 5 have had a relapse. But it's really that long-term outcome that matters. So for those individuals who were identified early, 40% have had a relapse by 2 years, versus 80% when there was a delay in getting care. So really, that year or more, you're looking at, you're 2 times more likely to have a relapse, which often results in hospitalization. So this is some data. Course of illness, again, early functioning tends to be the best predictor of later functioning. So looking at how they were before their illness started should help you set your treatment goals for where you're headed in treatment. Right now, if we were to look at disability rates in schizophrenia, because of the lack of adequate care in the United States, we see that 20% of Social Security benefits are used to care for individuals with schizophrenia. So something that affects 2% of the population requires 20% of Social Security benefits. And this is often because, again, individuals are impacted at such an early stage in their life when you're trying to establish independence, get a further education, get a job, start a family. That's when the illness is starting. And so once they're stable, they come out on the other side of this developmental period, and they've missed so many like opportunities or chances to develop their skills that it becomes harder to get them back into the workforce or back into education. And so individuals end up on disability and then stay because they don't have the skills and treatment hasn't supported them towards recovery. 25 to 50% of individuals with psychosis, with schizophrenia, will attempt suicide, and 10% will complete. So this is very high risk in the early phase of the illness. Remember, we talked about this concern that people were violent towards other people. That's not the case. Individuals with psychosis are more likely to be a victim of violence, and they are also more likely to aggress against themselves than against other people. So for those of you who were part of the Columbia training, that's why this is so important for the work that we do, you know, being very proactive in monitoring for suicide risk. The most important part of this slide is that recovery is possible. We are not just trying to control their symptoms. We are trying to hold the hope for them that they will be able to get well, be independent, and be able to pursue a meaningful life. That, again, is what everyone wants. And so that is our goal in providing treatment, is to get people back to where they want to be. One of the most important other predictors besides DUP is engagement with family and support persons. So for those of you who may work predominantly in adult system of care, for individuals with psychotic disorders or other serious mental illnesses, the ability to build their natural support network is one of the best predictors of outcome for them. We tend to take this like, oh, confidentiality, HIPAA, I can't talk to other people. You're doing your client a disservice by not getting those releases of information to help reinforce and educate their support network, because that's who's supporting them when you're not around. So we really need to support the families or other chosen families that these folks have to buffer them for stress in the community. All right, when do the early signs of psychosis occur? The earliest signs, those at-risk signs, appear 1 to 3 years prior to full psychosis. So there's this bubbling that we see as people head towards a full psychotic episode. Why does it happen during this age, this sort of early adolescence? Why does it take this time? There are aspects of brain maturation that are happening that are critical for appropriate, typically developing brain function. But for these individuals, something in that system has gone awry. And that, so that developmental period is leading them to cross the threshold into psychosis. I mentioned before that psychotic symptoms exist on this continuum from sub-threshold to fully psychotic. So these early signs look like changes in thought or experience, behavior, and functioning. So we talk about, instead of hallucinations, we say perceptual abnormalities. Instead of delusions, we say unusual beliefs. Instead of bizarre behavior, we'll say uncharacteristic behaviors. You know, we don't want to use the same terminology because the person isn't at that level yet. We're talking about these attenuated symptoms. So when I talk about this psychosis continuum, you know, I talk about things being within cultural norms. So these are experiences, again, that many of us have had that don't really, we don't get distressed, it happens infrequently, doesn't really affect your behavior, and it's consistent with cultural beliefs. So again, feeling your cell phone vibrate or hearing it ring when it actually didn't vibrate or ring. I'm sure if I asked folks on this training to raise their hand, many people would do so. This happens. It happens when we're tired or stressed. We don't take our phone apart and think that someone's communicating with us. We just say, ugh, I'm so tired, I need to get some sleep. It's within our cultural experience. So then we have fully psychotic. So these experiences, they're happening frequently. They cause us distress. We think it's real. And as a result, it affects our behavior and our functioning. Two ends of a continuum. What happens in between is what we call attenuated or subthreshold psychosis. So at the lowest end, we would think about something that is increasing in frequency. Maybe it's happening once a week. And as a result, we're wondering what's going on. Why do I keep thinking my phone is ringing when it's not ringing? What's wrong? You know, and so we start to question it. We start to wonder. We are meaning makers as humans. When we see patterns, we try to make sense of them. Okay. And so maybe there'll be some distress. Maybe I'll go to my husband and I'll say, I keep thinking my phone's ringing. Has this been happening? Is something wrong? You know, and he'll be like, no. And I'll sort of keep wondering about it. I'm able to question it. I'm able to doubt it. It's not really going to affect my behavior in a major way, but it's bothering me. Then maybe things start happening more often. And as a result, you see this increase in distress. It's starting to seem real. There's something going on that my phone, I keep feeling it vibrate when it's not vibrating. Something is happening, but I'm still not convinced. And it may be starting to impact my behavior or my functioning. So this is this continuum that goes from within cultural norms all the way up to fully psychotic. I'm going to give you an example. It's a personal example. It's about ghosts. I love ghosts. I grew up in the South. We love ghosts. I'm sorry. They're amazing. I've been on ghost hunting tours. I've watched, ghost hunting shows. I have a bunch of books on ghosts. It's like totally a thing. So, and it's also very culturally prevalent. So I think it's a good example. So within cultural norms. So when I was 12, my grandmother lived in my neighborhood. She had a house in my neighborhood. She was my primary caregiver when my mom was at work. So I was very close to her. She passed away. And so we were staying at the house and packing it up after her funeral. And I had a room there with a bed. And that my bed, when the door was open, looked down the hallway. So after her funeral, we went back, we were packing things up, and we stayed there that night. And I went to sleep. In the middle of the night, I woke up for no reason. And I sat up and I looked down the hall. And I saw my grandmother standing there. And she smiled at me. And she disappeared. Now, for me, that wasn't unusual. That was within cultural norms. The next morning, I woke up and I was like, Mom, I saw Grandma last night. She smiled at me. My mom was like, that's fantastic. That means she's at peace. So in my culture, that was interpreted as a very, helpful experience. Nobody tried to put me on Risperdal or take me to the hospital. It was something that happened one time. I felt comforted. It didn't change my behavior. It was consistent, with my family's beliefs. So this is very common after stressful situations, loss of a loved one. People smell, hear, feel a loved one. This is a good example of something that might seem psychotic, but really isn't. Now, let's pretend that after that, I started seeing shadowy figures a few times a month. So I was 12, and I would lay there in bed at night and I would see these shadowy figures and I didn't know why. It made me sort of nervous. I wasn't sure. I talked to my mom. She was like, "Ooh, this is different. This hasn't happened. This is concerning." And it was making it hard for me to fall asleep. This is an example of that lower end of attenuated symptoms, of that clinical high risk range. And these are kiddos we serve in our clinic too. So this would be an appropriate referral to us. Now let's pretend that I'm now seeing them daily. And, I'm starting to sort of wonder if maybe I'm seeing ghosts, or maybe the dead are trying to communicate with me. So I could have two different interpretations of this same experience. I could see it as exciting. I could think I might have a special gift, a more grandiose interpretation. Or I could be terrified. I could think these are demons that are trying to get me, and I could be very, very scared. So you can see how that cognitive interpretation of the same experience creates different emotional reactions. So let's pretend I'm going the more grandiose route and I have a special gift. So I'm starting to wonder, if I can communicate with them. So I'm laying there at night and I'm trying in my mind to communicate, see if I can get these shadowy figures to move. And maybe they move, maybe they don't. And again, this isn't consistent with my family's beliefs. And I'm tired in the morning. It's starting to impact my schoolwork. This is moving up that continuum of psychosis. So now if we want to illustrate this at the psychotic level, you know, each day I think I see these shadowy figures or even fully formed figures of people who've died. I believe that I can communicate with them. And I, you know, try to talk to them at night. I sit up at night talking. And as a result, I'm not able to go to school anymore. You know, my family is telling me that this isn't happening. And so I get angry and I lash out at them. So it's causing me a lot of problems at school and with my family. This is the level at which we would think someone has psychosis and is needing more significant treatment. Okay. So hopefully that helps everyone to kind of see this continuum. And I'm sort of wondering how many of you now have seen clients before where you're like, oh, that person had attenuated psychosis, or wow, I now think that person might have been fully psychotic. Or it could be conversely, man, we thought that was psychosis, but maybe it wasn't. Maybe there were some cultural factors or other experiential factors that were contributing. Important issues to consider: developmental norms. Again, we've talked about younger kids or non-typically developing kids where thinking about thinking is really difficult. So I've given you some examples of how to be more concrete. Do they hear those voices outside their head, like they hear my voice now? Do they identify that voice as someone different than their own internal monologue? I also think it's very helpful to look at the effect on behavior. When you're talking to the voices, in that moment, you think they're real. If you do something differently because of your beliefs, you think that they're real. Some behaviors are normal for younger children, but not adolescents. This is also developmental appropriateness. Imaginary friends in a 4-year-old, likely normal. Imaginary friends in a 14-year-old, I want to talk to them. That is much more unusual. So really making sure and sometimes families can make attributions about it. They're very creative. They live in this world of characters. And really they could be living in a world of hallucinations and not having friends or not going to school because of it. We've talked about the cultural and familial context, that belief in ghosts or other religious experiences. There are religions who believe that talking to ghosts is normal. So how does your client's experience differ from their larger community or their religious community? Are there behaviors or are there thoughts in some ways unusual to other folks who believe similarly? And then environmental factors. You know, they may be concerned about their safety, but is that realistic? Are they being bullied? Are they in an unsafe neighborhood? Those are realistic concerns that shouldn't be ascribed to paranoia. And so one of the things I like to ask is, do their symptoms occur outside of a particular context? Where are places they've felt safe in the past? You know, do they worry about others' intentions in those contexts when those places have been safe to them? It's when you start to see that generalization that it can be a little bit more clear that it's psychosis. What else might I see? These specific psychosis symptoms occur alongside a variety of non-specific clinical issues. People come into the clinic because they're not able to cope, you know, they're struggling to cope with life. They might not be doing well in work or school. They're having trouble concentrating. Maybe they're withdrawn from family and friends, or they're having trouble taking care of themselves. You know, they come in saying, I'm depressed. And so really our goal as clinicians is to pull back that curtain of the initial presentation and say, what else could be going on? Okay, you're telling me it's depression. Well, have there been these other experiences? Is there trauma? Is there substance? Is there psychosis? Really just making sure we do a very thorough evaluation, because folks with psychosis generally don't walk into me and say, hi, I'm hearing some voices and I'd like some help for it. They come in saying, I have all of these challenges. And by the way, there's some voices too. So here are some ways to ask about symptoms. I really encourage people not to use the two most commonly used questions, which is, do you ever see or hear things other people don't see or hear? Do you ever think people are out to get you? These are highly stigmatized questions. They're used on TV shows. Like, please don't use those questions. They know what you're asking and they don't want to say yes. I really want to encourage you to use these other 3 questions. They're from the semi-structured interview that we use. And I like them because they're designed to get people talking. Do you ever feel like your mind is playing tricks on you? Do you ever feel like your eyes and ears are playing tricks on you? Are there ever times when you don't feel safe? These questions are designed to be broad, open-ended, non-threatening, and they can take you in a bunch of different directions, such as OCD, abuse, but it's also going to pick up on attenuated psychosis or fully psychotic symptoms as well. All right, what causes psychosis? You guys are probably on the edge of your seats, hoping for answers here that I am only slightly going to give you because we don't know. So I'm going to give you what we do know, and then you're going to have to sort of hold that ambiguity with your families. It'll be really challenging. They're going to want to know what caused it, and you're going to have to say, it's a bunch of different things. We're not quite sure. They'll ask you for things like, can you give me a brain test or a blood test? We don't have those for psychosis yet. Trust me, we're working on it. UC Davis, a bunch of places are working on it. We don't have it yet. Psychosis is a very complex disorder, as I have shown you. And to date, many of the ways we've tried to understand it were like a sledgehammer. And they really didn't tell us much. So we're kind of going back and trying to come in from different directions to understand other causal pathways. So in general, the way we like to explain it is through the diathesis stress model. You have some sort of biological vulnerability to psychosis. And then environmental factors influence that and lead to the expression of the illness. So there could be a variety of different things that interact with a person's biology to lead to the development of symptoms. This is no different for depression, anxiety, substance use. They are all the same. So genetics, so I told you, prevalence in the general population, about 2%. It is highly heritable. So we do know that genes play a role. So risk increases with relationship. So if you have a first degree relative, mom, dad, sister, brother, or fraternal twin, your risk is 10%. If you have an identical twin that has psychosis, you share 50% of your genes. And it's 50% concordance. So you have half of the risk. So this allows us to estimate that genes play half of the role in what's going on. Okay, so this is the point in the conversation with a client or their family where people go, great, well, where are the genes? Well, let's think about what genes are for a second, because I think many of us forget 7th grade science, where we learned about fruit fly, eye color, and whatnot, right? What we now know about genes is that they are complex. Genes don't code for behaviors. They code for proteins involved in brain structure and function. And psychosis involves structural and functional changes to several brain systems. So I talked about the frontal lobes. We also see impact in the medial temporal lobes with memory. So, and we know that this is the case because if you look in family members who don't have psychosis but share genes with an affected individual, they will also have changes in brain structure, function, and associated cognition. So if you have an individual, a client who has a lot of difficulty with memory, and we were to give them a memory test, we would see that potentially their parents or their siblings could also show some impairment in that same area. And so that tells us that these difficulties are tracking with the genes. Different genes may be involved in disturbances in different brain systems. So it's not like your genes like just code for this part of your brain. Genes code for all different sorts of things across the brain. They're very complex. So here are the multiple systems and multiple levels. So what we see here, this is a CT scan. Again, you all might have seen something like this in your abnormal psychology textbook, where one of the first images of brain abnormalities in schizophrenia was this view of the ventricles, that center section of the brain where the cerebral spinal fluid flows and keeps our brain healthy. Well, what these early, and by early, I mean 1970s, mid-1970s, we saw these images, not that long ago. We saw that for individuals with psychosis, particularly schizophrenia, these holes in the brain were bigger on average than for individuals without schizophrenia. And so this ventriculomegaly is what it's called, this ventricular enlargement. And so this created this idea that there was atrophy of this cortical gray matter reduction in psychosis. And so there was this neurodegenerative hypothesis. But now what we're seeing is there could be other reasons why these brain changes are happening. And so when you look at individuals in their 40s, you can't really make a determination about development versus degeneration. So this is one of the big changes that we see. This is a PET scan. We also see changes in the functional and physiologic activation of the brain. So I showed you that fMRI image before, and we see reduced or irregular activation. So the brain isn't kind of working, isn't ramping up or ramping down in different ways, effectively or efficiently to perform cognitive tasks. And then if we look down at the cellular and molecular level, we can see abnormalities in neurotransmitter function, as well as in cell changes. So here's some examples. These are little bumps along these are dendrites along the spines of a neuron. This is a healthy individual, and here's 2 individuals with schizophrenia. You can see they don't have those same connections, these connective places where neurotransmitters bind. And so it makes it hard for the cell to then function normally. So these are all of the different changes that we see across the brain in psychosis. So why is it hard to find the genes? Show me the genes. Well, different genes may be important in different families and different gene pools. There's a lot of heterogeneity. And so how the genes mix and mingle can also affect it. Remember, in this cluster of diagnoses, we have different individuals who show different symptoms. So they might have hallucinations or delusions or negative symptoms or cognitive impairments, very heterogeneous, but we're putting them under the same group. Maybe that's not the right thing to do. Maybe it's hard to tie the genes to a diagnosis instead of to symptoms. And this is the way the field is sort of shifting now. Many genes are involved and each has a very small effect. So there isn't one gene. This isn't an autosomal dominant disorder or a recessive disorder, which is what we tend to think about when we think genetics. So you could have these genes sprinkled everywhere, and all of us do. All of us have these risk genes in our families, or else they wouldn't have persisted. So they're still out there, and so it takes kind of the right folks coming together and then the combination with environment to lead to expression. Additionally, de novo or new mutations may account for more cases than originally understood. This came from breast cancer research. We applied new approaches from breast cancer research to psychosis, and we see that for some families, these genes or the dominant genes aren't running in the same way that we thought they would. And so this is when you hear a family say, we don't have psychosis. There's no one else in our family that's affected by this. Maybe it's a new mutation that in combination with the environment led to the expression of the illness. Conversely, to some other families where you'll ask about family history and they'll talk about a number of individuals who've had psychotic symptoms. And that means maybe there's more of a genetic component for the individual you're working. And then again, some genes depend on environmental stressors like birth complications to be expressed. So here's that vulnerability stress model. So we have genetic vulnerability from low to high for various things, and then stress from low to high. And so what we really try to talk to people about is, in some way for this individual, the stress, the environmental stress, and the genetic vulnerability or biological vulnerability have interacted to move them over this threshold from absence of symptoms to presence of symptoms. And we can't do anything about genes right now. CRISPR might have us there in a few years, but right now we can't do much about genes, but we can do things about stress. So our treatment is really going to focus on helping them cope with the stressors that they have in their lives, or reduce the stressors that they have in their lives to bring them back over this threshold to absence of symptoms. That's the goal of treatment. So what types of environmental factors might be playing a role? There's a bunch. Prenatal complications. There's a very large literature on the impact of hypoxia in the presence of genetic risk can lead to the development of psychosis. So one of the things I really encourage people to include in their medical history is asking about the pregnancy and the birth of the individual. Did mom have complications during pregnancy, or were there complications during the delivery? And so you're looking for things that reduce oxygen to the fetus. You can have preeclampsia, high blood pressure, that cuts off oxygen to the fetus. You can have the individual be born with the cord wrapped around their neck. That cuts off oxygen as the baby's being born. These are all things that reduce oxygen to the brain, that impact the brain's health, that can be seen as an injury. And in the presence of the genes, which again, we aren't sure which ones, can lead to increased risk for psychosis. Not definitive, but increased risk. Malnutrition. There's a number of studies that look at cohorts of individuals who experienced famine. And again, so you are lacking nutrition to the brain, and it's associated with increased risk for a variety of poor outcomes, but also psychosis. And then viral infections, particularly during the second trimester. So not that the first, there's also stuff about the first trimester. So while the brain's developing, having a viral infection contributes to inflammation. And there's a whole now neuroinflammation hypothesis of psychosis. And so this is why you're not supposed to touch cat litter or eat bologna or other kinds of meats and things like that. There's a lot of concern about your exposure to bacteria or viruses, that it can increase inflammation, contribute to a fever in the mother that can then impact the fetus. So these are all of the prenatal and perinatal factors that are associated with increased risk for psychosis for some individuals. Social factors. So adverse social and economic conditions. So living in an environment with a lot of stress, be it poverty, racial tension, lack of jobs, community violence. These are all things that create stress for a person and for a family, and can contribute to the onset of a variety of mental health conditions, including psychosis. Trauma is a big area of interest for us at UC Davis. And there's a very clear literature showing that traumatic events, the experience of traumatic events in particular, can be associated with increased development of psychotic symptoms. So this is a very hot area of research right now, and clearly an area where research on treatment is needed. Family factors. High stress in the family, poor communication. We talk a lot about expressed emotion within the family. So the families that sort of like yell at each other, curse at each other, threaten each other, get physical, that is a very high stress environment. And that's one of the things we try to target with treatment, is try to work on communication skills and problem solving within the family unit to bring stress down for everybody so that folks can be feeling and functioning better. But that's one area where treatment can be very important. And then drug use. We conceptualize drug use as an environmental stressor. It is something that takes the body out of homeostasis and puts it in a place of high stress that it then has to recover from. And so we really think of it as a stressor, or as a poor coping skill that the individual is using to manage whatever is happening in their life, but is also contributing to a destabilization of brain and body function that can contribute to the onset of psychosis. So these are all areas that we try to understand and support the individual and their family with. If it's an area that can be remediated or helped, we'll try to do that. Like drug use, let's do some good harm reduction treatment to get that person in a less stressful situation. But sometimes, such as adverse social and economic conditions, they might not be something we can fix. So then how do we help the family? How do we help the individual understand and be able to cope with those stressors, to be able to manage their symptoms? What are effective treatments? So we've talked about biological factors that contribute to symptoms. So medication is one of those that can be very, very helpful for individuals with psychosis. And some individuals are able to take their medications for a briefer period of time or at a lower dose and then titrate off. Some folks will try to reduce their dose, try to come off their medications, and they'll experience a relapse. So it's not always very straightforward in how medications will work and which medications work best for different people. This, again, is an area of ongoing research, but it's important for folks to feel comfortable talking about substance use and medication with you, and to talk about side effects, to talk about frustrations, because those are the things that contribute to folks not taking their medication as prescribed. And so that's a point of intervention and treatment as well. I've alluded to a number of the cognitive and psychological factors that we tend to think about in our treatment of individuals with psychosis. We work from a cognitive behavioral therapy perspective. So we talk to folks about how their interpretations of their experiences can impact how they feel about them. So can they shift how they're thinking about their delusional thoughts or their hallucinatory experiences to modify their beliefs as well as adjust their emotional reaction to those experiences. The cognitive model of psychosis really says that these experiences are just culturally unacceptable. And so when folks experience them, they get concerned and they develop this belief that this thing is happening, as opposed to being like, oh, that's a really odd thought, and letting it go. So that's really, we try to bring back that cognitive flexibility so that folks are able to reduce their distress associated with their symptoms. I mentioned how the cognitive symptoms as well as the clinical symptoms can really impact an individual's functioning or ability to be in school or work. So a very important intervention that we use is supported education employment. So a dedicated person to help them get accommodations in school, figure out the best way to perform in a work setting or what the right work setting is, helping someone get job skills so they can get a job, different things like that to really support them in either maintaining their functioning in a work or academic setting or building towards what they're capable of in a work or academic setting. It's not usually something that's included in mental health. Oftentimes it's carved out to Department of Rehab. But what we've seen for individuals with psychosis is that separateness of systems is really difficult to navigate. And so by having an integrated person or integrated approach to this work, they're able to access it and really engage with that better than if it were a separate system that they also had to negotiate. Cognitive remediation is a computer-based intervention that is basically exercises for the brain. It helps to train up those pieces that are impacted by psychosis and build those connections back up so that the system works more efficiently. Brain HQ is a really great example of this, been supported by a lot of science. You can get it and put it on an iPad and do it at home. It's very popular in the aging literature, but we're really trying to bring it more and more into the mental health literature. And then skills training. Great example being social skills. If somebody's been struggling for a while, they might not know how to make friends or, engage in a conversation. And so giving opportunities to learn and practice skills is also a really important part of treatment for some individuals with psychosis. And then environmental and family factors. So recognizing that person, that individual doesn't exist in a vacuum. They have some sort of immediate support network or family, and then they have a community, and then they live within some larger system. All of these different pieces can impact how they're doing on a daily basis. And so our work within EDAPT really focuses on bringing those natural supports in, including them in treatment, providing them with psychoeducation, providing them with skills and support so that they feel like they're adequately able to support their loved one. So we do a lot of peer and family support, and then integrating folks into family therapy or group therapy, again, to enhance their skills and knowledge. What do we provide? We provide the evidence-based practice for psychosis. It's called coordinated specialty care. So we have a team approach where I like to say we wrap the client and family in our services. We are not a wrap program. We are not high intensity services. We are comprehensive outpatient. So we have a weekly team meeting where we discuss all of our cases and make sure they're getting adequate care. All of these people are sitting at that table to support that client. So we have our clinic coordinators. They're that first contact. They do all of our referrals and screening. They support folks with case management. We have physicians who do health and medication management. Everyone's assigned a clinician who does gold standard assessment, psychoeducation, and trauma integrated CBT for psychosis. We have supported education employment to keep people in worker school, get them back to worker school. We have a family advocate. She has lived experience. Her daughter has had psychotic symptoms, and she's just there to help our families be able to get the support they need so they can be present for their loved one. We have a peer case manager. She has lived experience, and she really supports our clients individually and helps to link them to services. And then we have a bunch of different groups. We have groups for the families and clients to teach them psychoeducation and skills. We have SAM, substance abuse management, to help, again, a harm reduction approach to substance use. We have a family support group, a peer support group, an expressive arts group, as well as cognitive remediation. So you can see there's a variety of different things here that we offer to our clients and families. We do a lot of community education and outreach to reduce stigma and increase referrals, and those go into our clinic coordinators. Our physicians collaborate with primary care to ensure the health of our clients. And then throughout our treatment, we're doing a lot of relapse prevention and crisis management to keep people out of the hospital. And then we regularly evaluate our outcomes to show the impact of what we're doing.